Hey there, and welcome to the deep dive. You've sent us something really useful here, a set of your own revision notes focused on a pretty common skin condition.
Yeah, these look great. Structured notes like these are absolute gold when you're revising, aren't they? Helps cut through the noise.
Totally. So our plan today is to take these notes you've made on allergic contact, dermatitis, ACD, and really, dive into them together.
Sounds good.
We want to unpack everything you've pulled out, turn this overview into some really solid, high-yield knowledge for your revision. We'll just follow the structure you've set out.
Makes sense. Lead the way.
Okay, let's unpack this, starting right at the top with how your notes actually define ACD.
All right. So according to the notes, allergic contact dermatitis is skin inflammation. But the key bit is it's specifically an immune response.
Ah, right. So not just any old rash from touching something.
Exactly. It happens when your skin contacts certain substances that trigger your immune system. It's not like, say, a chemical burn.
It's your body's defense system reacting. Yeah.
Oh, precisely. And your notes correctly put ACD under the bigger umbrella of contact dermatitis, basically any skin reaction from external stuff.
And you've highlighted a really important distinction right at the start here. Most contact dermatitis, like 80%, is irritant contact dermatitis.
That's right, the commonest type. Irritant CD is direct damage, think strong chemicals, or even just washing your hands loads with harsh soap. It just damages the skin barrier.
Yeah.
But ACD, the allergic type, that's about 20% of cases. And like you said, it's fundamentally different because it's immune-mediated.
That immune part seems crucial. Your notes flag up type IV hypersensitivity. That really jumped out.
It is absolutely crucial, definitely high yield. Type IV is a delayed hypersensitivity reaction.
Delayed. How so?
Well, unlike, say, an immediate peanut allergy reaction with antibodies, type IV involves specific immune cells, T lymphocytes. These cells get sensitized to something over time.
Okay.
And it's their reaction later on that causes the inflammation.
Ah, so that's why it doesn't flare up instantly. That makes sense. It explains why it can be tricky to figure out the cause sometimes.
Exactly. That delay is fundamental. Your notes also list a few other types: subjective irritancy, acute and chronic irritant CD, phototoxic or allergic, systemic protein CD, just to show the range.
Right, it's a complex area.
But the focus here is clearly allergic CD, and that delayed immune mechanism is specific to this type.
Got it. Delayed cell-mediated immune response.
Okay.
So that leads us nicely into the etiology section in your notes, the causes. What actually triggers this?
Well, the notes are clear. It's an allergic reaction caused by direct skin contact with something you've become sensitized to, an allergen.
And they list some usual suspects, don't they? Things people bump into often. Metals seem high on the list. Nickel.
Absolutely. Nickel in jewelry, belt buckles, coins, that's a classic. But also things we use daily, like cosmetics, fragrances and lotions or perfumes.
And latex is mentioned too.
Yeah, latex gloves, for example. These are common triggers, and repeated contact can sensitize people who are susceptible.
Okay, so that's the what. What about who? Who's more likely to get ACD? Your notes cover risk factors.
Right. The notes point to a history of atopy as a key risk factor.
Atopy, so that's things like eczema, asthma, hay fever, that sort of general allergic tendency.
Exactly that. If you've got that background, your notes suggest you're more prone to developing ACD if you're exposed to these allergens.
And it's not just about your inherent biology, is it? Lifestyle and jobs play a part too, according to the notes.
They definitely do. Occupation and lifestyle are listed as big ones. Think about jobs with constant chemical handling, hairdressers, cleaners, healthcare workers with gloves and disinfectants.
Construction workers, maybe?
Yeah, cements, resins, regular exposure in these jobs really ups the risk. It's a major occupational health issue, actually. Something worth considering regarding your own daily routine and exposures.
Right. So we touched on the type 5e mechanism. Let's dig into the pathophysiology bit in your notes. How exactly does that immune response cause the rash we see?
Okay, so the notes describe the immune system reacting to the allergen touching the skin. This sets off that type IV hypersensitivity cascade we talked about.
The delayed one?
The delayed one. Basically, those sensitized T cells spot the allergen on the skin again and release inflammatory chemicals, cytokines.
And those chemicals cause the redness and itching.
Exactly. What's fascinating here, as the notes imply, is it's not the allergen itself doing the damage, like an irritant would. It's your body's reaction to it. Your own defense system kicks in, maybe a bit too strongly, and that's what causes the inflammation.
Wow. So your body's trying to help, but the reaction itself becomes the problem.
Pretty much sums it up, which highlights why getting rid of the trigger avoidance is so central later on.
Makes total sense.
Yeah.
Okay, now, Skin rashes. Notoriously tricky. Lots of things can look similar, right? So if someone comes in with what might be ACD, what else could be going on? What's on the differential diagnosis list in your notes?
Yeah, this is a really critical bit for revision. Getting the diagnosis right is key for management. Your notes list the main things to think about.
And I'm guessing irritant contact dermatitis is top of the list again.
Absolutely. Telling ACD apart from ICD is crucial. They can look alike, but the cause and therefore the long-term plan are totally different.
Okay, what else?
Your notes also include atopic dermatitis, common eczema, often linked to that atopic tendency we mentioned.
Right.
Then there are infections, fungal infections like ringworm or bacterial ones. They can cause red, inflamed skin too.
Makes sense.
Drug eruptions are on there too, skin reactions to medicines you take, and other rarer types of dermatitis. The main point really is that you need a good history, especially about exposures, and a careful look at the rash to sort it out. Managing a fungal infection needs antifungals. Managing ACD needs allergen avoidance. Very different paths.
Got it. How common is ACD? What did the notes say about epidemiology?
They mention the prevalence varies, but it definitely affects a lot of people. It's certainly not uncommon.
And it calls out one group in particular, linking back to risk factors.
Yes, it notes it's especially common in people who are occupationally exposed to allergens.
Ah, back to the hairdressers and healthcare workers.
Exactly. It underlines that ACD is a big cause of occupational skin problems, causing people to need time off work, potentially long-term issues. So understanding the numbers helps show why it's important from a public health perspective, too.
Right. Okay, let's get into the nitty-gritty. What does it actually look and feel like for the person? What are the clinical presentations in your notes, and how do doctors usually diagnose it?
Your notes list the classic signs: redness, itching, often intense itching swelling, the rash itself, and sometimes blisters or even oozing, particularly if it's quite acute.
And it appears where the substance touches the skin.
Usually, yes. It starts at the contact site. But the notes make a good point. The rash may spread a bit beyond that initial area.
Which could make it harder to pin down the trigger, I suppose. And the notes distinguish between acute and chronic presentations, depending on the exposure.
They do, yeah. And this is another really high yield point for recognizing it. With acute ACD, the lesions tend to develop maybe 2 to 3 days after re-exposure. That delay is key.
2 to 3 days after.
Oh, and what you see then is mainly intense itching and vesiculation, those little blisters, sometimes bigger blisters called bullae, and maybe some weeping or oozing.
So that delay isn't just theoretical, it's a real diagnostic clue. If someone says, I used this new cream this morning and broke out straight away, it's less likely ACD.
Much less likely than if they say, I was gardening a couple of days ago and now this itchy rash has appeared. That history, that timing is vital.
Okay. And chronic.
Now, with chronic exposure, maybe low-level contact over time or repeated episodes, the notes say it looks different. Instead of blisters, you tend to get dry, scaly skin, maybe cracks or fissures, and lichenification.
Lichenification. That's the thickened, almost leathery skin from persistent scratching.
That's the one. So seeing if it's an acute, weepy, blistery rash versus a dry, thickened, chronic one gives you clues about the exposure pattern. The notes link those directly.
And how is the diagnosis usually confirmed?
Primarily clinical, according to the notes.
So history and examination.
Exactly. A detailed history about exposures, what, when, where on the body, and matching that to where the rash is and what it looks like. That's the standard approach.
But what if it's not clear-cut? If the history is vague or the rash looks odd, your notes mention investigations then.
Right, and this brings up a practical point. When do you need tests? The notes suggest investigations are needed if you're unsure if it is ACD versus something else on that differential list, or if you just can't figure out the specific allergen from talking to the patient.
And the main investigation listed, the sort of gold standard.
Patch testing. Your notes highlight this as the key test to identify the culprit allergen or allergens.
How does that work?
It's basically putting tiny amounts of common potential allergens onto the skin under special patches, usually on the back. You leave them on for about 48 hours, take them off, and then look for a reaction that delayed type 5U reaction, usually at 48 and maybe 72 or 96 hours.
So you're deliberately trying to trigger a small, controlled reaction to see what they're allergic to.
Precisely. And as your notes point out, it's not just for finding the allergen, it's also really useful for confirming it is allergic dermatitis and differentiating it from an irritant reaction.
Okay, that's a key takeaway. Patch testing confirms the allergy as well as the specific trigger. What about the other test mentioned? Skin swabs, biopsies.
Yeah, they have their place. Swabs if you suspect a secondary infection bacteria or fungi getting into the inflamed skin. Biopsies are less common, really only if there is significant doubt about the diagnosis itself, maybe to rule out other skin conditions.
Right. Okay, so we've covered definition, cause, risk, mechanism, presentation, differentials, diagnosis. Now, the really crucial bit, management. How do your notes suggest treating ACD, especially thinking about the UK context?
The notes are really clear and emphatic on the number one approach, allergen avoidance.
Makes sense? Get rid of the cause, get rid of the problem. Sounds simple, maybe harder in practice.
It's absolutely the foundation. The notes state in the non-prescribing section that contact dermatitis resolves once you avoid the trigger. That's vital for patient education. If complete avoidance isn't realistic, then it's about minimizing exposure as much as possible.
And general skincare.
Yes. The notes also mention promoting good skincare using emollients regularly to help repair the skin barrier and switching to soap substitutes, which are much gentler.
Okay, those are the non-drug measures. What about prescriptions?
For prescribing, topical corticosteroids are the mainstay, according to the notes. They're chosen based on severity, the notes mention, following the steroid ladder.
The steroid ladder. Meaning starting low potency and going up if needed.
Exactly. Lower potency for mild cases or sensitive skin areas like the face, stronger ones for more severe rashes or thicker skin like palms and soles.
Are there other options if steroids aren't enough or suitable?
Yes, topical immunomodulators, things like tacrolimus or pimacrolimus, are also listed for use, often helpful on the face or for longer-term control. And then, for really severe or widespread ACD, the notes mention systemic corticosteroids, steroid tablets.
But they're reserved for severe cases only.
Strictly reserved, yes, because they have more potential side effects systemically, not for routine ACD.
Okay. What's the general outlook then, the prognosis section in your notes?
Generally pretty good, according to the notes. It says, good prognosis with proper management and allergen avoidance.
So find the trigger, avoid it, and things should settle down. But there's a but, isn't there? The recurrence risk.
Absolutely. The notes warn that repeated exposure may lead to chronic or recurring episodes. It really drives home why identifying that allergen and sticking to avoidance is so critical for the long term. It's not just a quick fix.
Right. Ongoing vigilance is needed. Finally, complications. What can happen if ACD isn't managed effectively?
Yeah, the notes list potential issues, especially if it's severe or exposure just keeps happening. Secondary skin infections are a big one. Bacteria or fungi getting in through the damaged skin barrier.
Nasty.
Anything else? Scarring can happen, particularly after severe blistering or infection. And also hyperpigmentation, that darkening of the skin where the rash was, which can sometimes linger.
So the key message there.
Your notes wrap it up well. Early identification and management are essential to prevent complications. It brings everything together, why understanding the diagnosis, the triggers, the management, why it's also important for revision. It's about preventing these outcomes for patients.
Absolutely. So what does this all mean? We've basically walked through your own notes on allergic contact dermatitis step by step, from defining it as that specific immune reaction.
Through the common causes like nickel and fragrances, who's most at risk, like those with atopy or certain jobs.
How that delayed type V reaction actually works, what it looks like acutely with blisters, chronically with thickened skin.
How you differentiate it from other rashes, the importance of patch testing for diagnosis.
And then the management, where avoidance is absolutely king, backed up by emollients and steroids when needed.
Finishing with the generally good prognosis if you manage avoidance, but the risk of recurrence and complications like infection or scarring if you don't.
Exactly. Following that structure you laid out really helps lock the information in place for revision, doesn't it? You built a really solid framework there.
It really does help structure the thinking. And maybe go back over the bits that felt newest or trickiest for you in these notes. Everyone latches on to different parts.
Definitely. And just thinking about it, that delayed reaction is quite distinctive, isn't it? So here's a thought for you to mull over as you revise. Given that ACD kicks in maybe 2-3 days after re-exposure, how might that delay actually complicate things, both for the doctor trying to diagnose it and for the patient trying to figure out what on earth they reacted to and then actually avoiding it consistently? Thinking about the practical impact of that delay could be quite useful.
That's a good point. It connects the mechanism directly to the real-world challenges.
Yeah. And look, learning all this stuff efficiently, especially when you've got exams looming, is crucial.
It really is.
And resources like this deep dive, where we break down your material, are designed to help with that. Just like the kind of focused tools and, Practice questions you can find over at passthemsra.com.
And freemsra.com too. If you're prepping for the MSRA, those sites are definitely worth checking out to complement your own notes and learning.
Totally. They can really help consolidate this kind of information.
Absolutely. Well, thanks for sharing your notes with us for this. It was great to work through them.
Yeah, fantastic notes. Thanks so much for providing the source material for this deep dive on allergic contact dermatitis today.